And we will upload this to YouTube. You'll have an embedded link on your key learning document, which will be shared out within a week. And you can share or reference this hopefully with colleagues and others on your team. Next slide. For our P2P event today, we have enabled our annotation feature at the top of the screen. You have a view options. If you click on that, you can choose a stamp and a little icon. I personally like the heart icon. And I am trying to go to my annotation. Teresa, is there a reason I can't, why am I not can't annotate? Other people are annotating. Oh, annotate, there we go. Stamp, choose a stamp. Let us know where you're located.
Wow, Colorado.
Yay, I was born in Memphis, so I like to see some Tennessee hearts.
Maryland. Lots of stars, lots of hearts.
Anybody from the middle of the US?
Montana, okay. Arkansas.
All right, maybe one more minute. Love to see that we have 44 participants. That's wonderful. Let us know where you are from. You can write it into chat if you like, as well as annotation.
California.
All right.
Oregon, California, coast to coast.
All right. I think we're ready for next slide. Thanks for being with us today. Today we're going to be having a peer-to-peer dialogue about the use of PDMP to identify high-risk patients. And Comagine Health's team is coming to you through a project with the Washington State Department of Health. Next slide. We meet the fourth Tuesday of every month at 10 a.m. Pacific Standard Time, June through August. We'd love for you to join us in the coming months. Next month, we're going to be talking about stigma with a rural sheriff, fire chief, and a tribal SUD provider. We'd love for you to be a part of that conversation. The following month in June, we'll be talking about cancer survivorship, opioid use and abuse. Please join us. Next slide. So we're going to quickly get into our panel discussion. And following that, we will have a 15 to 18 minute breakout group where we really love to hear from you, your best practices, your questions, and your thoughts about the discussion. And then we'll do a lightning round report out and a poll question. We're always looking for how we can be more effective in delivering this webinar, this discussion with you all. So please participate in the poll. And we're just really grateful that you're all here today. Next slide. We couldn't do this without our extended Comagine family. Our opioid work group is crucial in assisting us with our breakout groups. And we just want to thank the teams for stepping up and participating with us and sharing your time. And now I will hand it over to Dr. Michael Parchman to introduce the panelists and get going on our discussion.
Fantastic. Thanks, Maria. And thank you all for joining us today about this important topic. And one I think that sort of weighs on our minds on and off throughout our work, the opioid data to action work that we do, which is about the risk of co-prescribing opioids and benzodiazepines, or patients who are taking sedative hypnotics along with their opioids. And we have three panelists with us today who have a perspective on this. Tina Siri is the Senior Director of Safety and Quality with the Washington State Hospital Association, and I really appreciate her perspective as someone who's working across our state of Washington on how they partner with the state on the PDMP, the PMP data. Dr. Bradley Pope is the district medical director for the region east of the Cascade Mountains here for Kaiser Permanente of Washington. And he'll be sharing with us a little bit about an initiative or a project that they've embarked on in the last couple of years. And then last but not least, Albert Carmel. Albert is a clinical pharmacist and works in a federal qualified health center, the Peninsula Community Health System in Bremerton, Washington, and will bring to us his perspective as a clinical pharmacist about these issues and what's going on. So thank you, all three of you, for joining us today. I really appreciate your time. And Tina, I'm going to turn to you and just and start by asking, in 2017, the Washington State Legislature passed what we call House Bill 1427, and that bill was about safe opioid prescribing. So can you tell me a little bit about that legislation and what WISH's role is connected to that legislation?
I can, and thank you, Dr. Parchman, and good morning and good afternoon to all of you that are joining today. I'm really grateful to share a little bit more about WISH's role and how our perspective of House Bill 1427 here aligns with this endeavor. And so as Dr. Parchman alluded to, in 2017, we our state's legislation implemented House Bill 1427, and that really in general is consensus on our opioid prescribing rules. It was implemented with an overarching aim to really reduce the opioid epidemic in our state, and that was through consensus on these rules related to the prescribing and development of standard prescribing metrics. So uniquely, WISHA is, our hospitals are our members. And so our onus is how do we support our hospitals in this state with this language? How do we align in a collaborative, non-punitive and convening way to really drive this improvement effort? So we have a role that's outlined in this language to partner with state stakeholders. So our Department of Health, who supports us with access to the PDMP data, and our partner with the Washington State Medical Association, as a convening group and collaborative group, we convene to synergize this improvement. And so we have the Better Prescribing, Better Treatment program, which is a peer-to-peer clinician-driven quality improvement program. It supports and promotes safe and appropriate prescribing to really reduce that opioid misuse and overdose. It is a component of the Washington State's opioid response plan. And as I mentioned, this collaboration with as WISHA and WISMA, the Washington DOH, and the Washington State Health Care Authority, we really support peer-driven, non-punitive quality improvement. So we do this through opioid prescribing practices of really elevating what those are. We focus on preventing future opioid dependence and misuse, and then supporting an arm of access to treatment. We also focus on provider education, looking at ways we can collaborate with community partners. And then the prescriber data is really what tells the story. How do we use that data to drive change?
That's great. That's great. I appreciate that. And, I know that, it's really difficult to engage clinicians without data, to get them to have that conversation. So how does the State Hospital Association, how are you using data from our state's prescription drug monitoring program?
Yeah, so we have an outline that's carved into the language and to the law and how we access and leverage this data. And so there is a standard process where we receive data on a quarterly basis from the Department of Health, from the PDMP. And what we do is we take that data and provide quarterly reports. We have a few internal processes that have been standardized over the last couple of years to really create a most seamless opportunities that we can provide timely information to our hospitals. But we work with our hospitals on a bi-monthly basis to make sure that we have an updated list of the providers that are prescribing with the facilities. We want to make sure that we align specialties and provider types accordingly. And we create a secured way to share this data. So our hospital audience is our CMOs and or their delegates. And we create a user access link to seeing the data that's going on in their hospital to really tell the story of what's going on in their community, where they might be doing well and where they may have some opportunity. And that may be unique age groups. And I say that as we've stratified our data to look at pediatrics. So in our state, that is under 21 when we look at the data. And then our adult population. And then we have also added age 65 and greater as another way to stratify it and learn from that information. But this information is offered, on the opt-in process. So we need hospitals, the leadership, the CMOs and or their delegate to opt in to look at this data and use it to its best utility. And a second component of that data sharing is we partner with WISMA, and the Washington State Medical Association then has an audience that is all prescribing providers in our state. And so they work in partnership with us to coincide with these quarterly reports getting pushed out into the community where applicable.
What do the reports contain? Well, are there specific measures or data? I mean, what kinds of reports do you generate?
Yeah, absolutely. Happy to answer that. We show a rolling 2 years of data performance. So the prescribing above guidelines is the performance that our hospitals that have opted in and or the prescribers in our state that have opted in have the ability to look at this data from a statewide performance that can be looked at through the different age groups that I described. And then it also shows the hospital's performance. So how do you compare? We are able to support our hospitals and prescribers in looking at cohorts of different groups or specialty or prescribing practices within specialties. And then hospitals in a peer-to-peer, non-punitive way can work with prescribing providers to learn, what might be an opportunity if it's the above guidelines. So they can stratify to individual providers, but again, it's a protected quality framework.
Environment, yeah. So what is your long-term vision for this work? And is co-prescribing of benzodiazepines with opioids a part of your thinking?
Yeah, absolutely. Let me share a little bit about kind of our high-level perspective on opioid stewardship in general. The last 2 years has been challenging for all of us, and I think about this in our hospital sense of, what are the priorities? Where are we as we start to move into re-engaging on any type of quality improvement? And opioid stewardship has been identified by our board, our WSHA governing board, and a partnership with Oregon, the Northwest Safety Quality partnership is an engagement with Oregon and Washington hospitals. But that is, opioid stewardship is one of those key priority areas. So first and foremost, we have taken this first few months of the year to re-engage with our hospitals, re-look at opioid stewardship in current state, and really, where are we at with leveraging the data? How are you using this, and how can we support you with, identifying opportunities to use the data to inform improvement? So we're really targeting on those prescriber feedback reports and making sure that hospitals are leveraging those, and if not, let's understand the barriers. We have an opportunity to increase the opt-in in our state, and so we really want to continue to target that improvement. We also have identified in our data set that pediatric prescribing in our adolescents is an opportunity. So we have some targeted focus improvement on our pediatric program improvement aims. And we really want to continue to collaborate and synergize our efforts for this work. And so aligning with other campaign marketing opportunities, learning from hospitals on what's working well and sharing and disseminating practices. We're looking not only within our state and then with the Oregon partnership, but how do we look across several states and partner and learn from others on what's been implemented. We do see co-prescribing and some additional data stratification points as current ways that we're thinking that we can provide a little more informative way to identify our biggest opportunities here. So we do, and we are planning with our state stakeholders currently about how we can continue to refine the data.
Great, thank you. I really appreciate you joining today, Tina, and just want to ask if the other two panel members, Dr. Pope or Albert, if you've got any questions for Tina or any.
Great work, thank you.
Yeah. So Dr. Pope, let me turn to you. I understand that over the past couple of years, Kaiser Permanente of Washington has not used necessarily the PDMP, but your own pharmacy claims data that you have available to identify patients who are co-prescribed opioids and benzodiazepines and do outreach. At least initially, I think the outreach was to both the patient and the prescriber, and more recently, just letters to patients. And so can you tell me a little bit about why you chose this approach?
Well, Kaiser Permanente of Washington sells insurance, and about 2/3 of those patients get their care from our owned and operated clinics and Washington Permanente physicians and their prescribers in there. But there's about 1/3 of our membership that is getting care covered by their Kaiser insurance product from contracted providers across the state where we have no bricks and mortar and no Permanente providers. And unfortunately, there's a disproportionate representation of the high dose opioid and combination opioid benzo patients coming from that contracted network. We've got a lot going on using our guidelines for chronic opioid therapy, chronic pain management inside our internal delivery system. And so we wanted to think of, well, what can we do to impact those high dose and combined opioid benzo patients risk in the contracted network, when the prescribers in the contracted network. And initially we were focusing on just the very high dose patients and doing a lot of work to call for records from these external practitioners, review the records, write up very carefully written findings of those reviews, making recommendations, and then doing follow-up reviews to see if action was taken on those. And that was a very slow process. And of course, we're following metrics on this. And the metric that we were following is patients per 1,000 on greater than 90 MMEs. Well, the patients we were reviewing, looking at the very highest dose, were sometimes over 500. So if you cut them in half, they're still at 200. And that wasn't affecting the metric. It was certainly reducing the risk for those individual patients. But we wanted to see what we could do that would require a little less work. And we decided that, well, let's outreach to the patients and also let the prescriber know that we're doing this outreach to the patients. And so we sent a letter to the patients on greater than 90 MME, but less than 120 MME, or that were on BIAD. That's the combination of benzos and an opioid. And explain to them we're concerned about their safety. Maybe they should, and we would describe to them what the safety issues were. what the side effects were. You know, we laid out, well, you're going to be having problems with everything from constipation to accidental death. You're a higher risk for those if you're on these doses. So connect with your primary care practitioner, and that wasn't always the prescriber, and ask them about how to manage your chronic pain or your chronic opioid. And then we also gave them a list of resources having to do with sort of non-opioid treatment for chronic pain and depression. So we talked about meditation, sleeping well, books to read, cognitive behavioral therapy, opioid dependence treatment options. We even let them know about information from the Center for Disease Control that was information specifically for patients. And we had links to videos on topics around anxiety, chronic pain management, how to taper opioids, designed for patients. And then the letter that went to the prescribers was just letting them know that that's what we were informing the patients of.
I see. Okay.
Yeah.
What feedback, if any, did you hear? Did you hear any feedback from either patients or prescribers when you did this initially?
Yeah, I was concerned that I was going to get a lot of feedback from prescribers about, hey, what do you know about these patients? I'm the one managing them. Don't bother me. I got no feedback in that regard. That doesn't mean there weren't those thoughts out there, but no one bothered to contact me. The only feedback I got was actually from a primary care practitioner who was asked by the patient to be sure to send me a letter thanking me for sending the letter to the patient. And they had they had eliminated benzos and significantly tapered their opioid with the help of their primary care practitioner who wrote me the letter. That's the only written feedback. And we sent letters to a little over 140 patients and their prescribers. So, but the real feedback was we followed the opioid MMEs for those patients and whether or not they were on BIADs. And there was we followed them at 3 months and then 6 months after we sent that one letter. And in that population, there was a very significant reduction in the number of people who had on those high doses. They had dropped off that list of greater than 90, but less than 120. Only one had actually increased their dosage, and many of them had stopped using benzo. So we took that as you don't know about cause and effect.
Of course.
And we didn't have we didn't really have a control group. But we do follow this rate of high dose opioids and then benzos, and the experience that occurred in that population of patients that were sent letters was definitely different than our sort of native experience. So we took that as a positive response to that letter writing campaign.
That's great. So I assume is the program being continued, or are you planning on continuing it?
Well, what we've done is we're no longer sending letters to the prescribers. We did a campaign letting them know, hey, we're going to be sending letters now to all of our members who are on high dose opioids or the combination of benzos and opioids. And you may be getting questions about the letters from your patient, but we're no longer sending specific letters to the patient or to the prescriber saying, oh, your patients below got this letter. We don't do that anymore.
Yeah.
But we actually expanded it so that we're sending it to all of our members greater than 90 in all counties and in both the internal delivery system and the external delivery system. And those letters are going out twice a year now. Okay. Now, once we send one letter to a PIP member, we do not send them another letter later. But if there's a new person that shows up in our data,
I see.
And we do look at the PDMP as well, because often we find that our claims data is not a full representation of the opioids and benzoids that the patients are getting. People are paying cash for their opioids. People are using multiple, they may have coverage on their spouse or via their spouse and their own employment, and they're using 2 different insurance coverages to go to different pharmacies and get medications because they're concerned about oversight, for whatever reason.
Right.
So it's important especially when we do individual patient reviews, that we look at our claims data and the PDMP to get a better understanding of what is going on with this patient's care, and certainly as we follow trends.
Yeah. That's amazing. That's fantastic. So Albert, I'm going to thank you for that.
Yeah.
Really appreciate those insights. Albert, you are, can you tell me a little bit about the setting where you work and your role in that setting?
Yeah, so again, my name is Albert. Thank you for having me. I am with Peninsula Community Health Services. So we're a federally qualified primary care system that serves underserved in Kitsap, Mason, Pierce County of Western Washington. So to picture that on the map we had initially, it's the area directly west of Seattle proper. We serve about 35,000 lives annually through about 10 medical clinics, some school-based clinics, 7 or so dental clinics, and some mobile clinics as well. We have integrated behavioral health and substance use disorder services as well. And I imagine the reason why I get to join this wonderful panel is because I will hopefully be able to provide some perspective from kind of the front line of a smaller system. We like to think of ourselves as the little system that could here in Western Washington. So we're a rural, semi-rural, again, primary care system that has wonderful leadership and have been very fortunate to do some great things with the PMP.
Right.
So yeah, my current role here is with the substance use disorder program, really kind of working with local, state, federal grants, many of which have components that are leveraging PMP expansion to do exactly this work of identifying high-risk patients. I also work with the patients and the providers to do a lot of the education that we've been talking about, the other panelists have talking about the potential risks and the opportunities to deprescribe when benzos or opioids are identified that put patients at a higher risk. So we're trying to, weigh the risks and benefits of any comprehensive therapy planning. And then we work a lot with transitions of care. So again, as part of my role with the substance use disorder program, lots of transitions coming to and from either inpatient care, from jails, from more acute settings like hospitals, and trying to figure out where prescribing falls along that continuum of care regarding benzos and opioids. And then I'm also fortunate to be a part-time, I'm actually a pharmacist as well, and get to be in the more traditional dispensing role, so have some exposure to the dispensing realm using an integrated PMP in our medical record, as well as kind of a standalone website that we also have here in Washington State. So get to do a lot of fun things here.
Wow, that's you juggle or wear many hats. Can you tell me a little bit about, you have an in-house pharmacist, a pharmacy program. So how do pharmacists in your setting use our state's, the Washington State prescription drug monitoring program data?
Yeah, so we use it on a daily basis. Again, frankly, it's something that all of us are routinely logged into to make sure that we're assessing care as prescriptions are coming through. So again, we wear many hats here. So clinically, we are looking at the PMP, the Washington State PMP, to do some monitoring. So we're looking at medication adherence, fill history. Are patients picking up early? Are they picking up late? All that information is useful to us. And again, we're kind of looking at an individual level. We also have the capability of looking at more systematic reports, and we're very fortunate to have some of the reports pushed to us, similar to our other panelists here from a system level. But on the individual patient basis, we're doing a lot of individual adherence, fill history, and then identifying new prescribers, new pharmacies, other gaps in the overall clinical picture. So identifying when new prescriptions are popping up on the PMP, sometimes in between refills of existing prescriptions. So that is where the prescribers in Washington State are, I should say from the regulatory perspective, are required to check the PMP for all patients that are receiving Medicaid or are on a Medicaid plan. Pharmacists, dispensing pharmacists are also required to be checking the PMP prior to dispensing any controlled substance in Washington State for any patient that is on Washington Medicaid plan. So for that reason, from a regulatory standpoint, we're looking at it as well. And that's provided some consistency and hopefully some additional opportunities to identify when there are gaps in the overall clinical picture.
Sure. And last question, do you have an example or a story about a patient perhaps that one of your colleagues identified as being at higher risk using the PDMP, and what happened?
Yeah, absolutely. So again, one of these examples of identifying a new benzodiazepine prescription that was coming in from an external behavioral health provider. And so this came in the midst of a patient who is currently in recovery and remission on our in-house medication for opioid use disorder, or MAT program. So it was something that we identified in the clinic pharmacy. I think one of the things that's interesting about having more consistent checks of the PMP, that age-old adage of don't ask questions that you're not prepared to answer. And so when we find and identify that there are outside benzodiazepines, we've really had to find quickly what is the workflow to get that information to the prescribing team and making sure that they are aware of the situation. Again, there's no contraindication, and I want to stress this, that there's no contraindication. It's just managing the risks and benefits. And so really having the clinical discussions, we have medication agreements, as I think many on this call have. And so sometimes it's frankly just an oversight that the patient said, I was dealing with a lot of stress. I had a procedure or some sort of new diagnosis that came up. And so linking the conversation back to the individual prescribers, some internal, some external, and involving the patient in those discussions, it really promotes the chance from the pharmacy level to start those conversations and to have those conversations with the patient who's in front of us as well, saying, as Dr. Pope had noted, you're at a higher risk of X, Y, and Z potential adverse effects up to and including overdose.
Yes, yeah, that's a great example. Well, thank you for that. I just want to go back to Tina and Dr. Pope, and I would ask, do any of you have any questions for each other about what we've discussed this morning? Any comments, questions?
This is Brad. One of the things that occurs inside our EMR when a patient is getting care from a Washington State Permanente medical provider in our facilities using our EMR, we cannot write a prescription for a benzo or a opioid without inside the EMR clicking the tab that gives us the link to that patient's PDMP. So it essentially forces us to open that tab before we can sign the prescription for the opioid or the benzo.
Yeah, interesting.
Yeah, and that has opened eyes in some instances where we did not realize that the patient was getting prescriptions from multiple prescribers.
Yeah, perhaps from an outside provider.
Yes.
Yeah, that makes sense.
We have a question on chat from Jose Peña Bravo to Dr. Pope. Is there a relationship between Kaiser Permanente and the State Department of Health for access sharing of PMP data, similar to what was shared by Tina Siri? If so, how did the connection come about and how does it work? And I think that's questions open to probably all three panelists.
Well, I mean, the PDMP is available to every prescriber in the state, and so we use it, and we've incorporated that into our EMR to make it very easy, so we don't have to log in. We can just within our EMR go to that PDMP tab and see for any patient what's out there on the PDMP for Washington State, and that's updated daily, I believe. So,
okay.
Albert.
Just to add to that, I would also like to just more comment and thank Tina for all the work that her agency has done. It is something that our providers also receive, individual provider feedback, and as is fairly consistent, I know we have a lot of providers on here. We have providers that are very motivated to do the quality improvement work. And so sometimes just seeing the picture from outside perspective and seeing what the prescribing habits are really makes a impactful difference. And I've had multiple prescribers come to me and say, what can I do differently? How can we de-prescribe? I think it really does set up the stage for change.
Thank you for
Yeah.
that feedback, Albert. And I would just comment here, and I think I alluded to this earlier, as our opportunity to convene and learn from others. How do we collaborate? I'm just impressed by all the wonderful work, and our Wishes opportunity is really on a push of sharing the feedback reports. What we are still exploring and excited to learn is, what individual hospitals or health systems in both urban and rural communities are doing to make a small test of change or make a difference in how they're leveraging this data. So we are always looking for unique ways where we don't have to reinvent, but how do we create the spirit of sharing and continued collaboration? I think there's a lot of opportunity in that sense. And Jose, I think your question is that, or I can comment, is that, we, the information that we share is that one way, and it's, just an opportunity to circle around and look at how they're using the data. And to be honest with you, there are still hospitals and regions of our state that need support on how to best, look at that from a QI perspective. And it's, I would say we are making gains, albeit maybe slower than we may all want to have. But it's, that peer-to-peer learning and, again, non-punitive, how do we do this in the right way collectively? So hopefully that helps support your outreach in the chat.
Well, we're over time, and I want to give us time for small groups. And I'll just, again, thank you to the panel members for joining us today and for your insights and your comments. We're going to divide into small groups now for those of you who are participating in the call, and just talk a little bit about what's going on in your state or in your area regarding using the PDMP, especially around co-prescribing. And then we'll gather back, I think, at 5 minutes to the hour just to.
All right, we've got people coming back, so we'll give a few more minutes until we're all back from breakouts before we begin the sharing. You back?
I am back.
All
Great
right.
conversation. Just want to go ahead and do a report out, and this will be integrated into our key learnings document as well, a lot of what we talk about now, and we'll do a poll before we end our time together. Anybody from a breakout group who volunteered, are you ready to report out for us?
I can volunteer that there was an interesting conversation at the end of our time together about older adults and breaking out the data from the PDMP by age groups, because older adults are especially at risk of an unintentional overdose from either high dose opioids or combinations of benzos and opioids, and looking at them as a specific high risk group based on age and doing some outreach. What kind of outreach might that be? Interested in the letters to patients idea.
Yes. Anybody else ready to share?
Maria, I can report out for our group. We had a pretty lively discussion. We had some members who are at the beginning of this process and some that are much more advanced. We talked about the value of having a non-punitive system when you're using this type of a database, and the value of being able to understand what's actually happening with the patient. One of our members talked about they have the bridge supply that is given to their patients, and that can be, the system can be utilized to validate that that was given by a hospital and that this patient is moving forward with treatment. We also had one member who really stressed the fact that she was impressed by the non-punitive and the use of this as a clinical care system to enhance clinical care.
Thank you. Kevin or Emily from my group?
We started off talking a little bit about some of the functionality within the PDMPs, where some states may have metrics. They may call them risk scores, maybe lightening that verbiage so it doesn't have such a negative connotation, such as an assessment or clinical safety alert, might be a little bit softer and provide more clinical decision support tools for providers. We talked a little bit about also de-identified data. Some states might have challenges if you just have de-identified data. It makes it difficult to make some decisions.
And Emily, did you want to share about your program?
Certainly. I just shared with my group that I'm kind of here more to listen and learn about the functionality of the PDMP, because I work with people who are living with hepatitis C. The state of Louisiana has an enhanced access model to a generic Epclusa that is offered to everyone under Medicaid coverage at zero cost. So we're really aggressively trying to address hepatitis C, and we're reaching out to people based on surveillance data, and we actually look at Epclusa prescribing data as well to figure out how we're doing. So oftentimes the people that I'm dealing with, they are acquiring their hepatitis C through injection drug use, and they're skeptical of their contact with the medical system, and oftentimes accessing this Epclusa and curing their hepatitis is the first real successful contact with the medical system that they've had. So it opens up a lot of opportunity. I have had conversations with my clients that were, first of all, very skeptical about how I found them. I am the man, so well, how did you find me? And then they worry about what knowledge is out there about their prescriptions. So I just wanted to be educated and kind of learn more about that, so that I can give that information back to my clients in an educated way.
Thank you so much for sharing. Rebecca or Dave, do you have anybody to report out from your group?
I was with Dr. Parchment, so we reported.
Yeah, and Nikki Griffiths from our group is going to report out.
Yeah, this is Nikki. Just we kind of had a discussion about alert fatigue and walking that fine line of making sure these actions are all these alerts are actionable. So we thought that the patient letters were a good opportunity, as well as probably forcing the provider to look at the PMP report, or perhaps suggesting Narcan as an option, as opposed to just sharing an alert. So an actionable item along with that alert.
Great. Thank you for sharing. And we have Justin reporting out for Jamie's group.
Hey, yeah, my name's Justin Liff. I'm the program analyst for the Colorado PDMP. Also in our group was Leila Kretzer, who's the analyst for the Vermont PDMP, and we're kind of in a similar situation where both of our state's laws in terms of unsolicited reporting are fairly narrow, where when we do send an unsolicited report, it is only to the provider. It is a confidential alert. We're not able to share that with anyone else. And then, as far as law enforcement or licensing boards, they can only request PDMP data through an active investigation. In Colorado, they require a subpoena. And in Colorado here, we're actually working on a report to the legislature to try to understand whether anything should be changed with regard to our unsolicited reporting and with regard to access for licensing boards and law enforcement. And a lot of the discussions have really focused on, rather than coming up with new ways for regulatory or legal oversight, but for making it a better clinical decision support tool. So very interested in this discussion that you had, and very curious about how Washington navigated any concerns they might have had with, privacy of the information about a prescriber being shared with their employer or other groups. Going to be reviewing the bill itself, but if you have any insight into how Washington was able to navigate any privacy concerns, both for patients and for providers, in being more proactive in sharing this kind of information, that'd be very helpful for our report and very helpful for me to just kind of understand the nuances of what you've experienced.
Tina, would it be Tina, would it be okay if Justin reaches out to you to get your thoughts about that?
Yeah, absolutely. And Justin, and if I can't answer all of the questions, we certainly can convene with some additional state stakeholders. I think that would be a great opportunity. Thank you.
Great, thanks.
And I do think this will be a real focus of the key learnings. We'll do a little deeper digging for some of the resources that were mentioned. Any other comments or questions before we move to our poll questions? Thank you so much for participating. We're so glad you've been with us. We're going to conduct a poll and show the results before we're finished. We really rely on your feedback to make our presentation as meaningful to you as possible. So please take a minute to answer these 2 poll questions.
And while you're
Go ahead.
Your question. I just want to say thank you again to Tina and Brad and Albert for joining us today for this conversation.
Yes. Thanks, everyone. Just maybe 10 more seconds on the poll. And I want to highlight May is a discussion on stigma with a rural sheriff, district fire chief, and a SUD provider from a tribal community, tribal health center. Please join us in May. In June, we'll be talking about cancer survivorship and opioid use and abuse. All right, and as soon as our poll has been tallied, and we'd love to hear from you. If you want to give direct feedback to us, please contact us at comagine.org, 6bb@comagine.org. And we just really appreciate your feedback and the time that you've given us today. All right, we are wrapping up, and we will see you all in May.
Thanks
For
everybody.
your time.
Thank you. Bye-bye.
Thank you.
Bye, everybody.
Thank you very much.